Hi, everyone. My name is Lynn Hernandez, and I'm with the Desmoid Tumor Research Foundation. It's great to be here with you today for our webinar about pregnancy and desmoid tumors. Information is absolutely essential when it comes to managing and living with desmoid tumors, and each case is different. This conversation is not intended as medical advice for any individual problem or as a diagnosis, treatment plan, or recommendation for a particular course of action. This webinar is for educational purposes only, and it should not be used as a substitute for professional medical advice and services. The DTRF does not endorse any specific treatments or studies. So some of you have submitted questions for our webinar today, and they have been shared with our panelists. Please note that comments will be high level on this topic, and they will not be providing case-specific advice. If you have any other questions unrelated to today's webinar topic, please reach out directly to the foundation at info@dtrf.org, and we will do our best to direct you. So this is how we're setting up today. There are two different ways to communicate if you're an attendee. You can either use the Q&A function. We invite the community to post questions for our panelists there. And then also there's the chat function, which will not be monitored for questions during this session. You, our attendees, are welcome to share your own personal experiences in the chat. If you know someone who was meant to join but wasn't able to, please tell them that this recording will live on our website in our video library, and we'll be sure to notify the community when it's public. Be sure to subscribe to our newsletter at dtrf.org for notifications. Okay, so our esteemed panelists joining us today are from Dana-Farber Cancer Institute, Harvard Medical School, and Brigham and Women's Hospital. Today we have Dr. Suzanne George, who is Chief of the Division of Sarcoma at the Dana-Farber Cancer Institute. We have Chandrajit Raut, the Chief of the Division of Surgical Oncology at Mass General Brigham. Dr. Catherine Economy, Chief of the Division of Maternal Fetal Medicine at Mass General Brigham, and Program Director of Cancer in Pregnancy at Brigham and Women's Hospital. We have Dr. Elizabeth Ginsberg, Director of the Fertility Preservation Program at Brigham and Women's Hospital. She's also a reproductive endocrinologist. Doctors, we are so grateful to have you with us today. I know that you're all working hard in the clinic and university, and we thank you so much for taking the time to be with us. Dr. Raut, I will turn it over to you.
Thank you. Thank you, Lynn, for organizing this along with Pearl Isleva. First of all, I'd like to thank all of the attendees for joining in today. I know this is a topic that comes up quite a lot in our clinic, and so we wanted to address some of the most recently published data to provide everyone with what we know about desmoids and their role in pregnancy. So I'm going to start with a few slides. Let's see. Okay. Let's see. Oh, I'm just looking at the wrong view. Hold on. Let me try this again. Let's see if this works better. It worked great during our practice run. Okay, and now let's see if that shares properly. Okay, there you go. All right. So everyone can see the regular screen view. Is that correct?
Yep.
Okay, perfect. All right. So this webinar will focus specifically on desmoid tumors and their impact on pregnancy or their role in pregnancy. So the association between desmoids and pregnancy has been recognized even before what we now know as desmoids were coined as desmoids. And John McFarlane's report dating back to 1832 from the Royal Infirmary in Glasgow, he noticed that these masses that we now know as desmoids, as he called them, organized sarcomatous tumor between the layers of the abdominal muscles in women who had children. He noticed that there was this association with between this tumor and pregnancy or women who had been pregnant. The term itself, desmoid, of course, was first coined 6 years later in 1838. However, there's very little that's been studied about that relationship. And so this became an interest not only for our group here in Boston, but also for several other groups in Europe and in North America. And so we first put together a paper that was published in 2014, combining data from our institution here in Boston, as well as our collaborators in Milan, Paris, and Toronto. And then more recently, earlier this year, we published a follow-up study that included data from our 4 institutions and as well as survey data done in partnership with DTRF and the Italian Desmoid Foundation, another patient advocacy group there. And so I'm going to focus on the data that came out of this more recent study for this webinar. So in this more recent study, we had 155 data on 155 women who had had 177 pregnancies. We also had a separate survey that included 775 women, and I'll show those data later. So for the first part of the study, which was the actual data on women who had undergone either been pregnant after prior treatment for desmoids or had noticed a desmoid arising during their pregnancy. So we categorized the participants in this study into 3 different categories. Those that had desmoids diagnosed during pregnancy, that was group A, that was 18% of our patients or our participants. Group B was those who had desmoids present at the time of pregnancy. So those are individuals that were under active surveillance for their desmoid. That was 95 pregnancies, so a 53.7% of our population here. And then the third category, C, included women who had previously undergone removal of their desmoids and had subsequently been pregnant. There were 50 pregnancies for that, 28.2% of our patients. So one of the questions that we get quite a bit is, if I've had a prior desmoid and then have a pregnancy, what is the probability that the tumor may progress? And so this table may be a little bit confusing, but so for most of the women had in our study had just one pregnancy at the time of their desmoid diagnosis or before or during their desmoid diagnosis. If they had no prior progression, that was 93 women, the probability of progression with a pregnancy would be about 10%. If they had had previous progression prior to getting pregnant, that was 45 women, the probability of progression during pregnancy was 65%. So that's a big jump, and that reflects the tumor biology of that desmoid, how it had behaved before pregnancy and then how it might behave during pregnancy. If this was a second pregnancy and there was no prior progression at before diagnosis, before pregnancy or during that first pregnancy, then the probability of progressing during the second pregnancy was less than 8%. If they had progression at one time point, either before getting pregnant or during that first pregnancy, then during the second pregnancy, the probability of progression was 41%. If they had had progression before getting pregnant the first time, and then again progressing during their first pregnancy, the probability of progressing during a second pregnancy was quite high, 78%. So you can see there's a huge difference, again, based on the biology of that desmoid tumor and how it's behaved in that particular individual. And we only had, again, these numbers are small, and we only had one woman who had had 3 pregnancies with 2 prior progressions. And so her probability of progressing was 57%. So that's how to interpret the table. It's a little bit different in the paper, but I tried to spell it out in a way that I think makes it a little bit easier to understand when reviewing the data. Now, what is the overall estimated probability of progression either during pregnancy or postpartum, irrespective of how it behaved before? So in the first group, those that were diagnosed during pregnancy, because it was diagnosed during pregnancy, the probability of it growing during that same pregnancy is high, about 69%. And then progressing postpartum, less than half noted progression. Of those who had, and again, in this category, a quarter of individuals needed active therapy postpartum. So they would not there were individuals that after a period of initial active surveillance needed some form of intervention, most commonly surgery to treat their desmoid. Of these other two categories, those women who had had a diagnosis of desmoid before pregnancy and either had it removed or were under active surveillance, the probability of progressing during pregnancy, irrespective of how the behavior had been prior, was less than 10%, and within 1 year postpartum, 8%. So only 5% of those women needed active therapy postpartum. So again, this reflects the fact that desmoids that are not diagnosed during pregnancy tend to be relatively well behaved. Now, we know from a number of different studies, including the two prospective trials that I'm sure most of you are familiar with, the sorafenib study and the nirogacestat study, that a large number of desmoids do spontaneously regress. We saw that with this group of individuals as well. We noted that during pregnancy in group A, we don't expect that those desmoids would shrink because they were first noted during pregnancy, but over a quarter were spontaneously regressing within 1 year postpartum. Of those that had a diagnosis of desmoids under active surveillance at the time of pregnancy, 21% actually regressed during pregnancy, which is higher than I would have anticipated, and 40% regressed within 1 year postpartum. Group C, we don't have these data because they all had their desmoid removed prior, so there was nothing to monitor. And finally, if we look at it by pregnancy rather than by individual woman, we found, again, that the regression rates were fairly similar to what you saw here. One phenomenon that we saw that we were able to observe here more closely is after initial period of progression, what kind of regression were we seeing? And many of you may be familiar with data from France, or from the Netherlands and from Italy, where desmoids can grow for a bit and then spontaneously regress. And we saw that in over a quarter of women after initial progression, that we could see subsequent regression spontaneously without any intervention. This from the same paper just shows tumor size measurements. So this is group A, the women who were diagnosed during pregnancy. We see the way to interpret this is just look at the solid lines. These individual dots represent tumor measurements at different times. And so what we see here is that most of the spontaneous tumor regression happens by around 2 years. So it's not immediate, but it takes a little while. But then after about 2 years, the tumor size reaches a new steady state. In group B patients, those that had tumors present prior to pregnancy, what you see is that for the most part, for that group of women, that was the largest group, that was 95 women, that the tumors had relatively stabilized prior to pregnancy. These double bars represent the 3 trimesters of pregnancy. And there wasn't too much change during that time, and there was maybe a modest shrinkage, but basically the tumor had already sort of reached a steady state and was not going to shrink further beyond where they were prior to pregnancy. This table summarizes some of the pregnancy outcomes, and Dr. Economy is going to put this in the context of overall obstetric outcomes. But these are just the numbers that we reported. There were 26 individuals unfortunately lost their pregnancy spontaneously. One was related to a desmoid tumor, but the majority were not. And then the rates of gestational diabetes, intrauterine growth retardation, placental complications, and a preeclampsia or eclampsia are also shown here. Peripartum, these were some of the outcomes that were noted: dystocia in 6.8%, fetal distress in 4%, hemorrhage in less than 3%, and other complications noted as well. Now, as I mentioned, in addition to the 177 pregnancies that we evaluated for those outcomes that I just showed you, we had a large group of women who were of childbearing age between the 20-year period here, 2000 and 2020. That was 775 women who were childbearing age during that time period. And we asked them some questions about their decisions around pregnancy. And we found that essentially having a prior diagnosis did seem to have some impact on their decisions around family planning. So what we noted was that 20% of women had electively postponed pregnancy. And when we asked specifically, was it due to desmoid, we found that the majority of those women, 142 of those 155 women, postponed plans for a pregnancy due to the desmoid diagnosis. Now, some women also avoided getting pregnant altogether. That was about 35% of the respondents to the survey. And of those, 3/4 avoided pregnancy due to desmoid. Now, we don't know if that was due to medical advice or due to their own decision, but that was a relatively high number. And then finally, 25 women opted to terminate a pregnancy, and over half terminated the pregnancy due to a desmoid diagnosis. I think the point that we want to make here is that there was, I think, advice often given in the past about concern about pregnancy in the setting of a prior history of desmoid. We do know now that with more data that pregnancies can be carried to term on an individual basis, whether the desmoid is pregnant or whether the desmoid's been removed. And that's a point of for further discussion with an expert team for any woman who's pregnant with a desmoid diagnosis. Another question we get is about whether contraception can trigger tumor growth of desmoid tumors. So this is a French population study that was published in 2022. The panel A here shows that in red, the red line here is women who had a history of a recent pregnancy. The green line is women who did not have a recent pregnancy. And basically what this shows is that during pregnancy, desmoids grow. The panels B and C look at different types of contraception. This is an estrogen-progestin combination and a progestin alone. And there's no significant difference between the lines for women who had no contraception, or sorry, estrogen, progestin exposure, and those that had it tumor growth during exposure and then tumor growth after use of this contraceptive. And similarly with the progestin exposure. So there's no real difference. And the point here that the investigators reported is that contraception does not appear to trigger, this form of contraception does not appear to trigger desmoid growth. They control for size, site, frontline approach, meaning observation or surgery or drug therapy, and for pregnancy. Another question that had come up in the questions that were submitted before this webinar was about the role of cryoablation. The issue around and this is just a slide I had from a previous talk about different ablative techniques that have been studied in desmoid tumors. As you can see, the numbers are relatively small, and these studies were simply reporting the efficacy of these techniques: cryoablation, high intensity focused ultrasound, or HIFU, transarterial chemoembolization. And What we don't have are data on how many of these individuals might have been women who wanted to get pregnant or were pregnant, and thus the impact on tumor growth during pregnancy or with subsequent pregnancy. So we don't. It's an important question. We just don't have enough information on how any of these ablative techniques might affect potential tumor recurrence during subsequent pregnancy. I'm going to turn this part over to Dr. George to talk a little bit about the two drugs, and then sorafenib and nirogacestat. I don't know if you want to address that, Dr. George.
Sure. I'm happy to. Talk about these two drugs. So sorafenib is a drug that's in a category called multi-targeted tyrosine kinase inhibitors. It's basically an oral therapy that's taken daily that hits a number of different protein pathways that are thought to be important in the growth of tumors. To be honest, exactly why it works in desmoids, I don't think is well understood, but it was an observation a number of years ago that there were some people that were treated with sorafenib and the tumors got smaller. And this led to a large randomized phase 3 trial where patients with desmoids were randomized to either receive sorafenib or a placebo, basically a drug that was no active treatment. And this slide summarizes the outcomes from that study. And what you can see in the blue line of the graph is patients who were on placebo, and the red line is sorafenib. And basically what we're seeing. Oops, sorry.
Yep.
What we're seeing is that patients on placebo had more events of growth than patients on sorafenib. And then on the other side is what we call the waterfall plot and the swimmer's plot, which is individual bars. And there's more bars going down on the top in sorafenib than placebo, suggesting there was more tumor shrinkage for patients on sorafenib. But importantly, as Dr. Rout mentioned at the beginning of his slides, some patients on placebo also had tumor shrinkage. So that means that the tumors on their own, without any intervention, had tumor shrinkage. And so this becomes really important when thinking about not just what drug to use to treat desmoids, but also when to consider using a drug like sorafenib. Clearly has effectiveness in desmoids, but some people's tumors will get smaller on their own. So it's really important to personalize when it's time to actually consider the use of sorafenib. Sorafenib is a drug that we certainly we encourage patients not to get pregnant while they're on sorafenib. And you can see changes in menstrual cycles when you're on sorafenib. And usually for women that were regularly having their periods, when you stop sorafenib, usually it comes back, but not always. And that's when we tap into our colleagues like Dr. Ginsberg to help us think about that if there's a woman that's interested in pregnancy after being on sorafenib. Next slide. Nirogacestat is the other drug that you hear a lot about in desmoids. This was also evaluated in a randomized placebo-controlled trial. So once again, some patients received nirogacestat, some patients received placebo. And what we saw was a similar pattern to what we saw with sorafenib, meaning with nirogacestat, patients were less likely to progress. So the tumors progressed less quickly on nirogacestat than they did on placebo. But I think the next slide.
Oh, I don't think I included the, no, yeah, I didn't include the waterfall plot.
That's fine. But the waterfall plots actually are very, very similar to what we saw with the sorafenib and placebo arm trial, meaning spontaneous regression absolutely occurs. But regression occurs more frequently with nirogacestat. So the decision to use it is very much individualized and balancing the side effects against what that particular person needs at that time for the management of their desmoid.
Right, I think that's it for my slides. Yeah.
So maybe what I'll do is just say one more thing, Chan, if that's the last slide about nirogacestat, which is that if you are have worked with your care team with nirogacestat, one of the things that we know is very common with that drug is that many times women will stop having ovarian function. So these are young women, they'll stop having their menstrual cycle, and really working closely with our reproductive colleagues around understanding what that means, better understanding recovery of ovarian function, is something that we take very seriously and that we work closely together on. Chan, did you have any other comments, or should we go into?
Oh, I guess maybe I'll ask Dr. Economy about just the obstetric outcomes. Maybe I'll pull up those slides again just for you to put that in context while getting started.
Sure, thank you. And thanks for inviting me here today. I've had the pleasure of working with all the individuals on this panel, and I think that's one of the best ways and most fortunate ways to be able to care for patients is in this type of multidisciplinary setting. I will say, as I watched your slides go by, it occurred to me that one thing that is probably not as apparent is that pregnancy is a time where people who may never have been in care present to care, and they come frequently to the doctor. And so we often see that certain tumors or certain diseases are diagnosed more frequently in pregnancy. I think a function of that is that many people are not in care regularly. And they come and they tell their obstetrician, you know, I have this lump here that I've always had. Now it's getting a little bigger. So I sometimes wonder if there's a little bit of an ascertainment bias when we see an increased incidence of things in pregnancy. If it's more that we're just detecting it more because women are otherwise young and healthy and not really coming to see the doctor on a regular basis. And so pregnancy is always an opportunity to pick up things that people may not have been aware that they had. And pregnancy itself is probably not the culprit in many things, but rather just an opportunity for us to see patients and care for them better. When we look at these obstetric outcomes, and the next slide, both antepartum, intrapartum, postpartum, really many of these are actually lower than we see in the general population. And I think this is a function, again, just of small sample sizes. Many things like dystocia, which means sort of like obstructed labor or need for a C-section, right? Those are very individually managed, right? This is a multi-center study. We don't have good data on how people practice obstetrics there, but none of these really raise a signal to me that anything is particularly associated with increased pregnancy risk with having a desmoid tumor. Even the spontaneous loss rate, we quote much higher loss rates, frankly, to our patients in general than 15%. We think probably at 20, 25%, and Dr. Ginsburg probably has higher numbers of all early pregnancies end in spontaneous loss. And so again, I wouldn't want people to see these numbers and think that they are higher. If anything, I think our rate of preeclampsia is probably more like 5%. Fetal growth restriction, by definition, the rate should be closer to 10%. That's how we define growth restriction, less than 10th percentile. So again, I think that these are numbers that should feel very reassuring to people.
Okay. Thank you. I will stop sharing and then I'll turn it over to Dr. George for the questions.
Yeah, no, I think that sounds great. Thank you so much, Dr. Roudamy. I think that was a really wonderful overall summary, and it's so helpful to have Dr. Economy put that into context with pregnancy in general. And I think it's really, really helpful to think about it. So I think that was an important takeaway from Dr. Rout's talk. And I wondered, maybe Dr. Ginsburg, if there was anything in particular that came up through Dr. Rout's presentation that you think are important takeaways before we get into some more specific questions.
I think from the standpoint of pregnancy planning, it's very tricky. Everybody worries that they're going to be in the category that does poorly, especially when you're talking about these newer medications where there really aren't long-term studies on outcomes. So in terms of planning pregnancy versus not, I think that's a group of patients that we do tend to see for fertility preservation because they're anxious that they may be in the low percentage of patients that actually don't get ovarian function back after they go on one of these newer medications. So those were my thoughts.
You know, and I think that's so helpful, again, is to have that collaboration and the multidisciplinary team that Dr. Khanami mentioned earlier, is when young women or women of childbearing age are interested in preservation of fertility, and people are going to take a drug that could impact that. It's really important to have your whole multidisciplinary team involved in understanding what those risks really might be and how to optimally manage and assess those risks over time, particularly in desmoids, because sometimes they do spontaneously regress. So we need to always balance the intervention risks versus the non-intervention risks as well. So one question that I wanted to ask that came up in some of the questions that were submitted to us in anticipation of this panel was was how we think about hereditary risk. So for example, FAP, some desmoids are associated with a hereditary condition that we refer to as FAP, and that's defined by a germline or a risk gene in all the cells in the body that people could have inherited from their parents and could potentially pass along to their offspring. And one question that was previously asked is how do we think about hereditary predisposition in people with desmoids, and how do we think about that particularly as related to pregnancy?
So we have many examples of genetic disorders that we know are inherited in a certain way, and we've identified the gene for them. And one option that we are able to offer women who are interested in this with appropriate counseling is the opportunity to have some testing for the gene themselves. And if they are found to carry it and we understand the inherent pattern, we can make a probe for this gene that then we can detect in their embryos. And so working with Dr. Ginsburg, who in addition to fertility and preservation also does in vitro fertilization, patients would have to undergo the process of in vitro fertilization where eggs were obtained, sperm was obtained, combined, and then those very early embryos would have a cell biopsy. We would look for the gene of interest, and then we would only reimplant embryos that didn't contain the gene if that was an option. Now, sometimes we do this process and find that every embryo contains the gene, and then we have more counseling and conversations about would they prefer to have a embryo put back that they know has the gene. The other option is that if we know the gene and we can identify it and we have a probe for it, we can also test people early in pregnancy through procedures like chorionic villus sampling, which is a procedure we can do at 10 to 12 weeks of gestation, where we take a little tiny sample of the placenta and test the fetus for that, or amniocentesis, which we can do later in pregnancy at 15 or 16 weeks. We can test the amniotic fluid around the fetus to see if the fetus contains the gene. So those are some options for genetic testing. And all of it would be undertaken with very teams working together with genetic counseling and lots of careful thought.
In states where there is a fertility benefit based on their state insurance mandate, many patients have coverage to actually have the IVF treatment and the embryos tested for genetic diseases. I think there are about 13 states with really quite good coverage right now. California was just added as a state with coverage. So you need to check, obviously, with your physician staff and the insurance, the people that would know about the insurance there. And patients that have single gene defects that are thought to cause problems in pregnancies often are going through more than one IVF treatment cycle in order to obtain embryos that are going to result in an unaffected baby. Sometimes you can get more than one unaffected baby out of one treatment cycle. So there can be several embryos that are unaffected and usable, and it's very variable. A patient can have no usable embryos one cycle and 5 the next. It's just random luck in terms of which genes are distributed into which embryos in that treatment cycle.
That's so helpful. Another question that has come up is, are there any known risks to IVF in the setting of having a desmoid or a history of desmoid? I know, Dr. Rout, you presented the contraception data, but is there any data around IVF in the context of desmoids? And if not, how would you suggest somebody move forward?
Yeah, and it's not predictable. There is one study that followed patients with desmoids who underwent IVF, and there were a few patients that had growth, and the growth was pretty significant. This was the study. It was patients that were doing IVF for genetic testing. So that's what PGTM. So it's pre-implantation genetic testing for monosomy. And there were 3 patients who had about 6 centimeters of growth during the 2-week stimulation. So clearly some of these desmoids were quite responsive. And in this study, aromatase inhibitors were also used. So the patients doing IVF were actually on medication to keep their estrogen levels low. And even with that, there was desmoid growth in 3 of the 17 women. The other point that they made, and I don't think most fertility doctors would do this, is that one woman actually had continued her kinase inhibitor during stimulation and had a very, very poor response, which really could have been predicted because kinases are very important in egg maturation. So if people are on kinase inhibitors, we always stop them during IVF treatment.
That's again very helpful, and I think it also highlights how important it is to have collaboration with people that are really experts in these fields of fertility, and also not just experts in fertility, but experts in fertility and understanding the context of the drugs that we use in oncology. So another topic that comes up related to desmoids in pregnancy that I don't think we touched on yet is how prior surgery or the continued presence of a desmoid in the abdominal wall affects the ability for a woman to carry a pregnancy. And that's, I mentioned the abdominal wall, but sometimes desmoids can also occur in the mesentery and inside the abdomen. So how does that cause a structural problem when we think about the uterus growing and just pregnancy and delivery? How do we think about that? And that, I feel like that's a doctor.
I don't know. I was gonna let Chan start, or
Sure. Well, I can start a little bit. We have, I think that this is a really tough question because in the past we would recommend that anyone who is planning on getting pregnant who has a measurable abdominal wall tumor, or usually they're palpable, so we can easily feel them. We know that they're going to grow for the most part during pregnancy. We just don't know how. Some women might have significant growth, some might have very minimal growth, and so we would typically recommend removing it, and then we'd be very thoughtful about how we close the space where the desmoid was, usually within the abdominal wall, within the muscles of the abdominal wall, so the abs, the rectus muscle. And then so we don't have a lot of data. Having said that, now, especially now that we do active surveillance rather than any kind of intervention for most people with desmoids, at least as an initial step, we've also had women who've had small desmoids who said, well, let's just see what happens during pregnancy. And so those data are more anecdotal. We know that they grow, but we haven't seen that that's necessarily impacted the ability to carry a pregnancy to term. If they're mesenteric, that can potentially be have more impact, only because it's sharing the abdominal space with the growing uterus. But again, we've seen fairly large abdominal desmoids that grew during pregnancy in the abdomen or in the mesentery that did not necessarily prevent a woman from carrying to term. Now, again, now we're getting into sort of individual anecdotal cases, so it's really hard to make any generalizations. But it's not an absolute contraindication to getting pregnant. But I think it has to be really cautious, and there has to be a lot of collaboration between the specialist treating for the desmoids or taking care of the woman for the desmoids and the obstetric team.
Yeah, I think that again, when we have small numbers and not a common thing in the big picture, it's always hard to make general recommendations. We do, however, have several other models of things that happen in pregnancy that grow and actually cause a lot fewer problems than you might think. So for instance, fibroids are a very common one. So fibroid is a benign smooth muscle tumor. They are actually very well known to be estrogen responsive. They can triple, quadruple in size rapidly in pregnancy. And the uterus is kind of like, bully is probably the wrong word, but the uterus is like an organ that is going to make space for itself. And you have to remember, right, the uterus can grow a singleton baby, it can grow twins, it can grow triplets. So the body is designed to sort of expand way more than you think it wants to or should be capable of. So when I see sort of like a fixed desmoid, a tumor like a desmoid, or something that we are thinking might grow. Although interestingly, I was listening with interest to the slide presentation, and it seems like if you have a phenotype of progressing, then you have the highest risk of progressing. And if you are a sort of a non-progressor, right, then you may, that might help us understand like how to counsel people. But I think in general, what I think about more is surgical planning. So in the event that we're going to need to do a cesarean delivery, which, probably that's about 25% of patients who come in spontaneously laboring ultimately will need a C-section if they haven't had a baby before. Those numbers apply to those patients. Then I would want to always have spoken with my surgical colleagues about, what's the best way to approach this? Is it in a spot where we might have to enter, where we would normally make our incision for a C-section? And is that going to pose a problem? For those patients, if we know that in advance, then they might be a good candidate for removal prior to pregnancy. But for people who it seems like it might be out of the way or be able to be pushed out of the way by the growing uterus, that most likely will not cause us any trouble at all. And we just are going to be careful in our surgical approaches.
That's great. What about women who have had their desmoid removed in the past and then decide to have want to have a pregnancy, and maybe they had a really big abdominal operation? Maybe this was at a time when maybe they, for whatever reason, they had a big abdominal operation. They've had part of their abdominal wall removed. They've had mesh put in. How does that affect? So their uterus may be very flexible to do everything. What about the abdominal wall itself in terms of being able to take the growing uterus?
I would say again, for most cases, and here's a good example where frankly, Dr. Ginsburg and I talk all the time, and I say, please don't put back twins, right? This is not a good patient this is a good patient for a single embryo transfer. Those are the words we use. And I'll say it's always healthier for a pregnant person to not have a multiple gestation. People think that seems like a fun idea. Those of you who are parents know differently, but I think that in general, like, we would like one embryo, and we would like a singleton pregnancy. And in other cases where people have had abdominoplasties, we have examples of people who have reconstruction after breast cancer, where they've sort of migrated their entire rectus muscle up to create a breast tissue. We do know that the uterus will continue to push out, but in fact, if they have mesh, the fascia may expand laterally on the sides. And so it is possible, I think, that later on, they may be at risk after delivery of a herniation around their old mesh sites. But in general, the uterus will continue to grow, the abdomen will continue to push out. I do find in this patient population that they are more uncomfortable, but no real data that somehow it restricts we see growth restriction of the fetus, for instance. But
That's
definitely
great.
something I worry about and I follow with routine ultrasound surveillance of the fetal growth in the 3rd trimester.
That's great. So what do you think for recognizing that the expertise around desmoids varies, because these are uncommon tumors, and so not everybody lives in an area close to a high volume desmoid center, let's say. It's in general, who would you recommend is the right team? Like, who should women be asking to see? Like, what types of specialists should they say, gee, I have this history, I want to consider pregnancy? Who should they be putting together as their team?
I mean, as somebody who refers to Kathy, to Kathy's group often, somebody with really good surgical expertise, especially for patients that may have a tricky entry, patients who you think may well need a cesarean section. So, for example, women who have had fibroid removal surgery, their uterus, they are always going to need a cesarean delivery. Having somebody with expertise in that, not so, the dermate, the presence or history of the desmoid may not be a factor, but the fact that they've had complicated intra-abdominal surgery and may have very bad adhesive disease, I think, potentially would factor into which type of OBGYN they choose. For example, I would never want a patient like that going to any kind of a birthing center or have kind of a doctor on standby. I think the delivery really needs to be planned well in advance.
That's very helpful.
Yeah, I would say some kind of if able, preconceptual consultation. And it doesn't have to be that they come and see me every pregnancy visit. We have lots of people that we manage in conjunction with lower risk setting to kind of address the issues like Liz is talking about, but also in general, most obstetric care can be managed by a range of people, but just 1 or 2 visits with a more multidisciplinary team virtually, just to think about it and to kind of like have a strategic plan, I think would be very helpful. Or to say like, actually, we think you can have a vaginal birth, but if you're one of those 20% of people who needs a C-section, we would actually want you to be in a center with this type of support, right? Even just having that conversation is going to be extremely helpful.
Thank you. So one of the questions that came in online, and I'm going to put this to you, Dr. Rout, is somebody asked whether the studies that looked at desmoid outcomes in pregnancy, was that limited to women with intra-abdominal desmoids or abdominal wall desmoids, or did it also include extra-abdominal tumors, for example, in the extremities?
Right. And I tried to answer that online for the retrospective study that we did. That included women who had intra-abdominal tumors, extremity tumors, abdominal wall tumors. So we wanted to try to get a good representation of all the different settings where we can see desmoids. And in our 2014 study, we did not include women who had FAP. We did include women with FAP in the more recent study. So we have some, so we have women who have different genetic mutations as well, therefore. What I remember the original phase 2 sorafenib study, and Dr. George, you can correct me if I'm wrong, but the phase 2 sorafenib study did not include abdominal wall, intra-abdominal desmoids, but the phase 3 did, I believe. And then I can't remember about the nirogacestat study.
Yeah, that also included mesenteric intra-abdominal.
Yeah, so they did all include women with desmoids at different sites. But again, the individual numbers of women in each of those, with desmoids in each of those places is going to be a small number.
Yeah, sounds good. Thank you. So another question that's come up is, this is from somebody that's had 3 babies, but asks the question about whether a desmoid is benign. And I think this is an interesting question. And you may get different answers from different people. And Lynn, you might even want to chime in, because I know this has been a real area that the advocacy community thinks very deeply about. I'm going to start by saying, in the strictest terms, because people will ask us this very regularly, in the strictest terms, we think of the definition of malignancy often implies that a neoplasm, a tumor, has the potential to metastasize and spread elsewhere. Desmoids are local issues. We don't think of a desmoid as metastasizing. But the issue is that desmoids can still, in some people, be life-threatening. It really depends on what part of the body they occur in and what structure they occur next to. So for me personally, where I sit in my clinic, I don't focus so much on whether something's benign or malignant. I focus on what is the risk to this person based on their particular clinical situation. Lynn, I don't know, do you want to comment on that? Because I know from an advocacy community, I know that's something that you all have thought about.
Yeah, absolutely. I'd be happy to. So we did launch a campaign this past year, the Spread the Word campaign, and the focus is that desmoid tumors are not benign. So the WHO classification, I believe, has 4 different kinds of soft tissue tumors. There's benign, malignant on either kind of pole, and then intermediate. There are 2 different classifications for intermediate. One of them is locally aggressive. Yes, one is locally aggressive, and that is where desmoid falls. So I know that when people use the term benign, there's kind of this implication that it doesn't metastasize. It doesn't metastasize. But if we're going by that WHO classification, and we encourage institutions to, we reached out to about 15 institutions over this past year that are leaders in sarcoma, and said, please make sure that your website is accurate, that it does not use the word benign when referring to desmoid. So that is absolutely very important. I appreciate the question.
And I think another important point is that the treatments that we use when active treatment is needed are often this. I mean, sorafenib is used for malignant tumors. The scope of an operation can be the same as it is for a malignant tumor. And even when the term benign is used, benign doesn't mean that it just means that it's only used in the context that it doesn't necessarily spread. It can still have, heart disease isn't malignant. But it can be life-threatening, or it can require significant treatment. So in the setting of a tumor, it still can, like a desmoid, it can still require the same aggressive treatments that cancers need. But luckily, active surveillance can work for a lot of individuals, and many of the tumors can respond or shrink without active intervention.
Yep, I think that's all really important discussion. It's really, what is the complexity of the use of that word, right? It's of the word. And I think I think the work that the DTRF has done in this particular space is really very valuable to the whole community, both of patients and of providers as well. So I think that's a really important question. So another question that came up in the chat is whether do we learn anything between, or do we know anything extra if we think about the time between an active desmoid and the consideration of pregnancy? So for example, if someone was treated for an active desmoid 15 years ago with chemotherapy, this is the example in the chat, was chemotherapy treating desmoid 15 or more years ago, and then considering a pregnancy later. What information does that give us?
Can you repeat that, Suzanne?
Is there what if a tumor has regressed in response to chemotherapy, and then 15 or 20 years later, that person wants to have a pregnancy? I guess I would think about that in two. So I have 2 questions around that. One is, does that long duration of quiet help us to understand the likelihood or not that the tumor would grow back? That's one. But then the other really important one is, how do we think about the impact of chemotherapy on fertility? So I think there's 2 questions there. So Chan, I don't know if when you did the multi-center study, if you looked at that question of time of quietness, let's say.
So not the time, and another question, someone else had also asked about a time interval, and we don't have data on time. We just have kind of data on behavior. What we don't have, which the question is really asking importantly, is if it became quiescent because of chemotherapy, then how do you interpret their behavior? Because to get that chemotherapy, now that tumor would have to have been growing. But in the past, that tumor might have just been sitting there and has a desmoid diagnosis and just got treated without really knowing how its behavior was. So if someone right now said, okay, my tumor started to grow to the point where we needed active therapy, that tells us that it was actually progressing. And therefore, based on the data, a progressing tumor previously is likely to progress during pregnancy. But in the past, if they got chemo for this tumor that was not really growing, it was just sitting there, that person has a different behavior of their tumor. And if their tumor was not growing before they got the drug therapy, then that might be better indicative of what their tumor overall behavior is. And that means that they probably have a lower rate of progression. So it's you have to take it into that context.
No, thank you. That's really helpful.
Can
And
I-
Liz, how do you think
Can I
about
just make a comment about waiting for pregnancy, though? So from a fertility standpoint, the main enemy of fertility is egg age. And so that's a tricky thing, too. If somebody has a tumor that's quiet or regressed, but they're worried it may come back, waiting longer is not good from a fertility standpoint because older eggs result in more miscarriages and lower chances of having a baby altogether. I don't know if this comes up very much with desmoids, but we certainly see plenty of patients who are very worried about cancer recurrence and will actually undergo IVF if they need chromosome or genetic testing of embryos, do that, and they have another individual, or what we call a gestational carrier, actually carry a pregnancy for them if the risk of recurrence or the risk of the concern about them going off their maintenance medication is high.
And I'll just add that we have a lot of experience in this with lots of other types of tumors that were treated in childhood and long-term effects of chemotherapy and radiation. And these are things we would very much like to talk with someone before they got pregnant, because I think maybe I saw someone had hip radiation or pelvis radiation. Like, these are things that may affect your pregnancy risk overall, your risk of preterm birth, your risk of fetal growth restriction. Certain types of chemotherapy that may have been used in the past are cause cardiotoxicity. So we definitely would like an opportunity before you get pregnant to think about if you have any pregnancy risk just from prior treatment, and then to plan in a rational way, like, what would we do if you did have a growth of your desmoid or recurrence of your desmoid during pregnancy? And I think that the important thing to remember is, while we may not be able to use some of the tyrosine kinase inhibitors that you're using, like, those are probably not safe in pregnancy, particularly in the time of organogenesis in the first 8 weeks. We can do surgery in pregnancy. And so that's something that we have also lots of data on safely performing different types of surgery during pregnancy, that fetuses can tolerate anesthesia and operative time. And we don't necessarily, like, if we had to do that, like, that could potentially be an option. So I think these are all things that, again, like, multidisciplinary conversation is really helpful too.
Great. Thank you. I think we may just be at time. What do you think, Lynn?
Yeah.
Contraception, we forgot to talk about contraception.
Oh, right.
As the obstetrician, I literally can't leave this conversation
Yes, that's
without
fine.
reminding people that contraception is safe. And we don't have any data that hormonal contraception will increase your risk for recurrence or progression. And it's always safer to, if you don't want an unintended pregnancy, it's always safer to not be pregnant. So please feel comfortable with your contraceptive choices.
That's a great OB public service announcement.
Wonderful, wonderful. Well, a special thank you to all of our panelists for sharing this discussion with us today. Just a quick reminder to our attendees that this conversation is not intended as medical advice for any individual problem or as a diagnosis, treatment plan, or recommendation for a particular course of action. It should not be used as a substitute for professional medical advice and services. This webinar is for educational purposes only, and the DTRF does not endorse any treatments or studies. We'd like to thank, again, our panelists and the community for being with us this afternoon. After being formatted, this broadcast will live again in our video library. Don't forget to sign up for our newsletter at ttrf.org so that you'll be notified when we post it. All the best.